Good evening, everyone. Today is a class on ultrasound, and I'll start Devika to start.
Good evening, everyone. I welcome you all for the today's discussion on ultrasonography in ocular infections and inflammation. To start with the introduction to the topic, as we all know that are the acoustic longitudinal waves consisting of oscillating particles with frequency more than 20 kilohertz. That is it is beyond the audible spectrum. In ocular ultrasound, we use around 8 to 12 megahertz of high frequency ultrasounds. Since the high frequency is the quality of these ultrasound is the tissue penetration is low, but higher at the resolution. Basically, the ultrasound works on the principle of pulse ecosystem. In the first diagram, we can see that this is the ultrasound probe, and this is the interiors of the ultrasound probe. In the interiors of the ultrasound probe, we can see that the electrodes which are here at the sides of the piezoelectric element stimulates the piezoelectric element, and on stimulation, the piezoelectric element starts oscillating and generating the longitudinal waves. These longitudinal waves are transferred through the transducer projected onto the ocular surface, and here the projected rays are reflected back, and these reflected rays are collected in the transducer and are sent to the receiver system. The echo waves are produced in pulsed manner, so it is called as pulse. And in between the two acoustic waveforms, the waves returning back are collected in the transducer. These waves are sent to the receiver system, and the receiver system displays it on the monitor, and we see the scan, which we see as a 2D image of the ultrasound. So, to start with the basic normal ultrasound, the first image shows the normal ultrasound axial scan taken with 12 megahertz B scan on the depth of the retina. Shows first this is the B scan image on axial scan. Along with that, on the right hand side, we can see the A scan. So, in normal ultrasound, we take the B scan image along with the A scan images so that we can correlate the frequency and amplitude of the waves. First A scan, this is the A scan of biometric variety, which we usually use for the axial power calculation. The first deflection, which is the high amplitude deflection, comes from the cornea, which coincides here in the ultrasound. The second high amplitude shows as the axial anterior lens capsule. The second waveform comes from the posterior lens capsule. In between is the hypoechoic or anechoic vitreous cavity, and the last fourth wave comes from the retina, and the low amplitude waves are from the orbital fat. Same ultrasound is A scan echoes are seen along with the B scan, suggestive we can correlate clinically. This A scan is standardized A scan, which we use in combination with the B scan. So now coming to the topic of today's discussion, ultrasound and first ocular infections. What are the highlighting points we should see in ocular infections is the first, starting from the anterior vitreous cavity, there we can see dot, clump, and membranous echoes. In cases of trauma, we should rule out intraocular foreign body with membranous echoes. Posterior to that, we can find retinochoroidal thickening, retinal detachment or choroidal detachment, subtenon space widening, subretinal abscess can be seen, and intraocular foreign body to be ruled out. All these findings are shown by the diagrammatic depiction in this diagram. So coming to the cases of discussion, a 60-year-old male patient came with complaints of pain and redness in his right eye, which was started 7 days back. And the left eye also complained of pain and redness 2 days later. Patient was diagnosed initially with hepatic abscess elsewhere and was advised to continue IV antibiotics. But because of his ocular complaints, patient took a discharge against medical advice from the hospital and came to our hospital for ocular opinion. On examination, the right eye vision was no PL. Extraocular muscle movements were restricted in all gazes. There was chemosis and proptosis and corneal edema with total cataract. So fundus view was not there. In the left eye, the vision was perception of light was present, but the PR was inaccurate. Extraocular muscle movements were present with 2 mm of hypopyon in AC with AC grade 4 cells. Pupil was small and non-dilating and fixed. There was fibrinoid membrane in the AC with no view of fundus. So both eye ultrasound was advised. This is the right eye ultrasound image.
Quickly enumerate, no?
Right eye ultrasound is showing a definitive lens echo. There is a membranous echo in the vitreous cavity, uh, showing high spike, most probably a retinal detachment with attachment at the optic nerve head. Thickening of the choroid is also noted. There is some fluid collection in the subtenon space.
So,
Uh,
what is the diagnosis?
um,
It's patient with hepatic abscess, EOM restricted with conjunctival.
Panophthalmitis, ma'am.
So, right eye panophthalmitis.
Right eye pan.
Next image. Another.
The left eye image was this.
Ultrasound B scan with vector A scan of the left eye showing a definitive lens echo, moderate dot echoes in the vitreous cavity. Then
So, in the second image, you can see how are the dot echoes distributed.
dot and clump echoes
In the right side image, you see they are mostly posterior.
posteriorly.
Yeah. So sometimes it may not be that cavity will be filled with echoes, especially in a case where there is, may not be in this case, especially whenever there is a corneal pathology along with end of, when you see the ultrasound. If the echoes are distributed closer to the postocular course, we may have to think more in terms of endophthalmitis. And sometimes you see few echoes which are just at the AVF, anterior, like just behind the lens or the IOL, which might be just reactionary secondary to the corneal pathology. So this way you have to. Okay, then
Choroidal thickening.
definitely yes, choroidal thickening. Next image. Okay, so what could be left eye?
Endophthalmitis.
Okay.
The patient was diagnosed with right eye panophthalmitis and left eye endophthalmitis. Patient was shifted to Apollo Hospital for the management of its systemic condition first. Patient came back after 14 days. That time, the right eye was auto-eviscerated with residual necrotic material, and left eye ultrasound was repeated. The ultrasound scan showed vitreous cavity full of dot and clump echoes and moderate reflective membranous echoes with clump echoes posteriorly. So patient, the blood culture from Apollo Hospital were suggestive of klebsiella pneumonia.
Devika, what is the mobility of the membrane? You told moderate reflective.
Yes, sir. The membranous echo were non-mobile on mobility and were not persisting in low gain.
They were not mobile.
Not mobile.
Okay. Attachments?
It was
Was it attached to the
not
optic nerve?
attached to the optic nerve.
Yes. So then what's your diagnosis? What is that membrane?
So it could be incomplete PVD because it was not attached.
Okay, but why was it
And,
not mobile?
So maybe the exudates were organized, giving the shadow of appearance of a membranous echo, and the vitreous cavity is full of clump echoes as well. Maybe the movement was less.
Yeah, but still vitreous membrane would be mobile, right?
Yes, sir.
Posterior hyaloid. Suppose that's the posterior hyaloid. Assume that
Yes, sir.
that should be mobile.
Yes, sir.
No, you told it is no. It was not mobile. If it was not mobile, I would think it more of retinal. You're not given any images which are showing any attachment near the optic nerve head.
Yes,
So
sir.
if you're telling it's not mobile, then I would think definitely as a retinal detachment. So it's a person who's doing the scan who can interpret. So if you're not done, probably you cannot opine on it. But you have to, whoever is reporting has to put down whether it was mobile, not mobile,
Yes.
attachments, and the reflective. All three you have to mention about any membrane.
So the blood cultures were suggestive of Klebsiella pneumoniae, and the sensitivity of antibiotics was it was sensitive to almost all the antibiotics. So patient was advised intravitreal vancomycin with ceftazidime and dexamethasone. After the first injection, the ultrasound was repeated. The vitreous cavity showed plenty of dot and clump echoes, as slightly reduced than the previous scan. The membranous echo were not noted. Retinochoroidal thickening was noted on the scan with PPCT of 1.72 millimeters. Patient was given second dose of V plus C plus D in the left eye, and right eye underwent removal of residual necrotic tissue debris. After the second dose of VCD, there were few membranous echoes which were high reflective on A scan, and the clump echoes were persistent. So patient underwent left eye vitrectomy. Gram stain and KOH mount came negative. PCR for Mycobacterium TB, Aniobacterium, and Panfungal genome was sent.
Go back. So what was that membrane? What is your opinion?
Sir, it is a high reflective membrane. It was documented that it was not mobile on and persisting in low gain. So it was suggestive of maybe focal retinal detachment.
Okay, it is attached to the optic nerve.
Yes,
so
sir,
yes,
it
it
was
could be
attached.
retinal detachment. Okay. Was that the indication for surgery, or was because there was poor response to the intravitreals?
So both the things. Actually, there was poor response also, and the vitreous cavity shows a lot of dot echoes as well. So maybe the only intravitreal medication won't suffice for the treatment, and debridement of the infected material.
That is one. Non-response to poor response would be an indication to go for surgery. Second thing, when you're suspecting retinal detachment, an ultrasound is showing a membrane, and you're thinking there's a retinal detachment, you can go in for surgery. So the ultrasound is going to give you a clue when to operate actually.
Yes.
So that's why we needed serial ultrasound.
What other sign you can see in this ultrasound?
Mild subtenon space widening is also noted here.
Yeah. This one, the next one, and even the previous scans also are showing
Yes, ma'am.
the. So what is the reason for that?
In
What would you suspect if you see previously it was not there and now it is there?
Ma'am, the patient might be going into the panophthalmitis. The scleral involvement also should be suspected.
Yeah, so probably patient is worsening. So you need to intensify the treatment and do the surgery also early.
Yes.
So whether there is indication for vitrectomy RD is there, not there, I think some definitive surgical step has to be taken.
After the vitrectomy, VCD was repeated on postoperative day 2 as well. Patient actually wanted further treatment at his local hospital, so the patient was sent there. Now coming to the second case of the patient
What
came.
was the intraop finding? Was there an RD or no RD?
There was no RD, sir.
There was no RD.
No RD.
How would you explain that membrane then? What you saw on ultrasound, you have to correlate clinically.
So maybe it was membranous echo secondary to incomplete PVD itself.
Okay, it could be a thick posterior hyaloid, which is now separating, and it's highly reflective, and probably may have less mobility also. It's possible. Anyway, this patient came to you after the YACAP, so somebody had seen before the YACAP.
Yes, before the YACAP
fundus was seen that time.
Yes.
It was normal. Okay. You go ahead, because in the ultrasound class, we'll go on to the ultrasound. Yeah. Who's describing?
Aditi, sir.
Yes. So this is the ultrasound of the left eye. IOL rebifurcation echoes are not seen here actually. I'm not able to make out. There are few multiple low to moderate reflective dot echoes seen more posteriorly. The retina appears to be attached, but optic nerve is not seen in the left or the right side scan. The left side scan shows the ONH shadow. There's no
So what is it basically? What is it inference? Or you can put it in differentials.
vitritis.
So either post-hoc inflammation or infection. It has to be one of the two. So you go on.
The first scan is the axial scan actually. This is the lens.
Why is there less echoes in the left side image and more echoes in the right side image?
Maybe the with echoes were inferior. This is the inferior transverse scan.
Yeah, it's possible that this was probably an inferior quadrant scan. It's not marked, but that is a possibility. Okay. Go ahead.
So patient was advised to first give a trial of topical steroids and then reassess. If patient was advised that if the reaction does not reduce, then we can consider the AC tap to rule out infective conditions. The ultrasound was repeated after starting the topical steroids. The vitreous cavity showed plenty of dot reflective.
Devika. So how many times? What day ultrasound was repeated? These two I think you should tell. So it was next day after hourly or 30-minute steroids. How was it?
Ma'am, after 4 days of topical steroids, the ultrasound was repeated.
What happened to the fundus view? What happened to the hypopyon?
So the hypopyon was persistent and the fundus view was still hazy. There was
Okay, it
no
was the
difference
same
of
fundus haze.
yes.
Okay.
So the repeat ultrasound showed comparatively higher amount of dot reflective dot echoes in the vitreous cavity. Uh, the retina was attached. After the next follow-up after 1 week, the left eye hypopyon was persistent with around 1 mm in height. There was still no view of fundus. So the AC tap was done and simultaneously VCD was given. The serial ultrasound was showing organized vitreous echoes, dot and clump echoes in the vitreous cavity, which were the PCR sample came positive for Propionibacterium immunobacterium. The hypopyon was resolved after the 2 doses of VCD. There was no fibrin in pupillary plane and PCR was stable. So patient is under observation and is advised to follow up after 1 week later. And if the vitreous echoes are persistent, we can consider vitrectomy. That was the action plan.
How many injections were given?
Total 2 of injections.
2 injections. With 2 injections, that became like
This is the last ultrasound after 2 injections.
What was the fundus view at the last visit? What is the vision?
After 2 injections, the patient came for follow-up. Fundus view was there till the second order vessels were seen, and so vitrectomy was deferred. As of now, patient
So
will come on
the clinical
today.
picture is more important than the ultrasound to decide on
Yes.
vitrectomy, right?
Patient will come for follow-up maybe
The
tomorrow.
ultrasound gives you a guide. Okay, so when you're not able to see clearly, it can tell you what is going on inside and helps you to decide the treatment. Okay, but the clinical picture is also very important. Okay, it's always you correlate the ultrasound with the clinical picture. Okay.
Yes. Coming to the third case, patient complained of pain, redness, and watering with loss of vision in left eye since 1 week. There was history of upper respiratory tract infection along with fever 2 weeks back. Patient was diagnosed as left eye endophthalmitis and was advised vitrectomy with intraocular antibiotics. Patient deferred the treatment and came for second opinion over here. Patient was not known case of any systemic illness. Visual acuity in right eye was 6, 6, and 6, and in the left eye it was 3/60 and 18. The intraocular pressure was 14 and 10 millimeters of mercury, respectively. There was no fundus view in the left eye, so the ultrasound was advised.
Hold. Zubin. Quick, Zubin.
Ultrasound image, no definite lens echoes noted. Vitreous cavity shows multiple dot and membranous echoes. Membrane echo with attachment to the optic nerve head noted. And the right hand side, there's a slight retinochoroidal elevation through which the vector is passing,
So with the background history, what that could be?
probably a subretinal abscess.
Good.
Patient underwent core vitrectomy with intraocular antibiotics. The
Just a minute,
subretinal.
Devika, just a minute. Zubin, what about that first ultrasound? There are two membranes.
Yes, ma'am.
So, what is your opinion on those?
Ma'am, the one with the attachment to the optic nerve head could be the IPVD membrane, a taut posterior hyaloid that's separating.
And what about the front?
The front is organized exudates.
Why do you call that IPVD?
Because when the vector is passing through the upper one and the spike is not, it's a moderate spike, it's not.
What else? So all those echoes are in what do you call, in connection with that membrane.
Yes,
So it's unlikely that it is RD, because it appears that it is continuous with that echoes in the front. So it is if you have RD, then you will have some separation between the vitreous and the RD. So first of all, the configuration is not like RD.
Yes.
Second, the reflectivity is also not like RD. And third thing is, if you see the echoes in the front along with the membrane, that is also not like RD. Go ahead, Devika.
Yes. So patient underwent core vitrectomy with intraocular antibiotics. Intraoperatively, subretinal exudation was noted. The blood cultures and urine cultures came negative. Patient was also advised ID specialist opinion, and he suggested IV meropenem to start. So patient was started on IV meropenem as well. PCR for eubacterial genome came positive, and fungal elements came negative. Patient was also added on intravitreal imipenem. On follow-up ultrasound, the vitreous cavity showed uh, moderate moderate amount of low reflective dot echoes, and along with that there was a high reflective corrugated membranous echo and few subretinal echoes as well in the inferotemporal quadrant extending from 4 to 6 o'clock, and the membranous echo was persisting in the low gain, so it was suggested that there is a focal retinal detachment.
Go back. There's one more echo in the left side image just above the line.
Yes, sir.
What is that echo?
It appears to be a clumpy only, sir.
What could it be?
The scan vector is not passing through it, so we can't tell about the surface reflectivity. But there's no attachment to the retina or any other parts, so maybe only a clumpy cone.
Anybody, any guesses? It looks like it is going up and attaching there to the retina. This eye which has undergone vitrectomy for end of.
Uncut gel.
Uncut gel, possibly, yeah. So when you're doing, you will see the mobility, and that's possibly uncut gel.
It's a drug precipitator. Could be drug precipitate also.
Another thing.
Why was the ultrasound repeated?
And post-operatively on day 2.
Why was it repeated?
No, ma'am. Fundus is my patient, ma'am. So fundus view only center that clearing was happening, and I wanted to image that subretinal abscess area. So actually, eventually he developed RD there, and that subretinal abscess exactly gave way, and he
What
means
is this corrugated membrane that you see? What exactly is that? That membrane which you have shown in both scans?
It appears to be retinal detachment focally in the inferotemporal quadrant.
Why the retinal detachment is like this?
Ma'am, in the next image we can see there was subretinal abscess in the temporal quadrant itself, and we were suspecting that the subretinal abscess only has given way, and there was a retinal break temporal to the macula. So maybe the subretinal abscess has burst out, and the retinal detachment happened there.
Could this
Devi-
be a vitreous membrane?
it's a retrospective diagnosis, ma'am, what she says. So, but initially I also thought it is a vitreous membrane. Could be an uncut gel also. We may not be able to do complete wit in end of case, but later it became subtotal RD and then realized that area has opened up. It was a retrospective thing.
So a retinal detachment can be exudative or rhegmatogenous. Okay, a subretinal abscess is a exudative detachment, so it will be smooth, dome shaped. Okay, so but this configuration is showing some corrugations. So it looks like uncut gel also, or that will also have this kind of thing. But like if it is persistent in eye gain, it could be like the conversion of the exudative to a rhegmatogenous detachment here, which is probably being shown in this ultrasound.
In this ultrasound, but you have to give a differential diagnosis of a vitreous membrane, because it could be a vitreous membrane. The endophthalmitis will have multiple vitreous membranes, and you should also look at the OT notes to see whether PVD was induced, whether any vitreous was left behind, how much of vitrectomy was done. Sometimes you will have exudates lying on the retinal surface, which will also appear like this. So it need not be retinal detachment. So you have to give various differential diagnosis, and also you need to look at the movement of this, whether there is movement or no. So to call this a retinal detachment at this stage is very difficult.
Okay. So patient was taken for lensectomy with endolaser and silicone oil injection. This is the optos image of the fundus where the subretinal abscess is seen in the temporal quadrant, and there was a break here. So probably the subretinal abscess has given away from here, and the retinal detachment was happened. So the part of subretinal abscess is lasered, and the break is also lasered. Post surgery, patient improved with vision of 6/12. So coming to the next case, patient came with a history of trauma to his right eye with iron filings while working in a factory 4 days back. He had complaints of pain, watering redness, and loss of vision since then. Patient had a vision of perception of light only, and finger tension was firm. This is the slit lamp photo of the patient with right eye. Patient underwent CT orbit elsewhere, which was suggestive of the intraocular foreign body. So the ultrasound was done in this case.
Ma'am, the ultrasound shows one definite lens echo along with the multiple dot and clump echoes in the vitreous cavity, and the right side scan inferior scan shows one localized high reflective membrane echo with some retinocoroidal elevation at that point.
With
The vector
reverberation.
scan shows passing through it shows a high reflective query membrane echo and with some retinocoroidal abscess probably.
What do you see post
Or
that
foreign
shadow?
body.
It's even seen in this left side image also. You can see something.
Foreign back shadowing that is showing
It's there.
probably IOF.
So can anybody explain why it was not seen in this scan? It is seen well in that scan.
So, ma'am, probably it was just perpendicular to it. So therefore, the high reflective this was picked up.
Yeah.
Perpendicular scan will show a better.
So this is very important. Any case where you suspect foreign body, even otherwise any endophthalmitis, especially post-traumatic, you have to do a proper scan to look for a foreign body. Okay. And so, is there any retinal detachment? Can you comment? Possibly, we don't know. Difficult to say, at least with the given images.
Go back. What are the information you want from the ultrasound? You know there is a foreign body. CT is showing a foreign body. Ultrasound is also showing a foreign body. What are the extra information you want from the ultrasound?
So one, are there any more multiple foreign bodies? Any site of
Okay.
incarceration?
Okay, site of incarceration.
Yeah.
Okay.
And retinal detachment. If
Okay,
if
presence
you
of
want to make
RD.
out,
Okay.
if the choroid is thickened, like if it is a long standing, and if you want to look at we're able to make out the choroid structure.
Why choroid?
Sometimes, like if it is sclerotic, this thing it can cause damage to the retina and.
Okay, but that would it cause choroidal thickening or something?
No, meaning thinning. Sorry.
Huh?
Meaning we just want to make sure that there's no retinal or choroidal detachments.
Choroidal detachment. Okay. Choroidal detachment. Okay, fine. What else you want to look for? You're anyway going to operate, right? So pre-operative planning, what do you want to know?
Positioning of the foreign body.
Okay, so position means what do you mean?
if it is in the mid-vitreous cavity or it is close to the retina.
Correct. So how will you know it on
So-
ultrasound?
Sitting position and lying down position.
Yeah, even eye movement. So
Eye
you will know whether foreign body is moving in the vitreous cavity or it is impacted on the retina.
Yes.
So that is very important for planning the surgery. What else? You want to induce a PVD. So you want to know if PVD is there or not, right? These all things you should look for while doing the ultrasound. Okay.
In the presence of so many vitreous echoes, how will you confirm the presence of a foreign body? Always.
Ma'am, if there's a hyper reflective echo, if there's a presence of back shadowing, ma'am.
Yeah. So now the vitreous is full of echoes. You are not able to locate the foreign body. Yeah. You should reduce the gain so that all these vitreous echoes will become less. Then you will be able to pick up the foreign body. So in this scan also, which is showing this one single spike, here also ideally the gain should be reduced to make it more prominent, because this spike what you see and the thin line that you see is not very much confirmatory of foreign body. So for any foreign body, you must always have two scans, one with a lower gain, which shows that the foreign body spike is still persistent.
So patient was diagnosed with right eye post-traumatic endophthalmitis with intraocular foreign body. Patient underwent vitrectomy with intraocular foreign body removal with endolaser and silicone oil injection. They aspirate isolated Bacillus cereus species. So patient was continued on intravitreal antibiotics. Patient was started on topical Ciplox and Dexa multiple doses. So after the multiple intravitreal injections of Ciplox along with dexamethasone, the final the outcome of cornea was improved to this, but unfortunately the retinal status was extremely poor. So the patient went into the no PL of vision. A 47-year-old male patient complained of sudden onset diminution of vision in his left eye with pain and redness since 1 month. There was no history of fever, no history of any systemic illness. After taking extreme more history regarding his habits and dietary patterns, patient was non-vegetarian and he was exposed. He said that he must have exposed himself to undercooked meat or improper hygiene. There was no contact with pets or TB patients. There was no history of joint pains, fever, rash, or any genital or mouth ulcers. Serology was showing ESR of 18 millimeters per hour. Anti-nuclear antibodies were negative and syphilis test was negative. On fundus examination, the right eye was normal. The left eye was showing dense vitritis. Along with that, there was a cystic lesion noted inferiorly in the retina, subretinally, with a suspicion of a spot inside the cystic cavity. So the diagnosis with suspicion of cysticercosis was made, and the ultrasound was advised. I'm sorry for the poor quality of image, but the ultrasound showed that the vitreous cavity was filled with moderate reflect. There was low to moderate reflective dot echoes. Along with that, there is a high reflective membranous echo posteriorly, and there is a high surface reflectivity cystic echo subretinally, along with a high reflective clump echo within the cyst. So this was suspected to have a cysticercosis. Subretinally, the cyst is present, and since the inflammatory reaction is there, so it was suspected that the cyst is degenerated and a dead cyst. So patient underwent left eye vitrectomy with endolaser along with cyst removal with C3F8 under steroid cover. CT brain was also done to rule out any brain or neurocysticercosis signs. And also the ultrasound was performed in orbit mode to rule out intraorbital cyst or intramuscular cysticercosis as well. A 13-year-old female patient came with complaints of recurrent episodes of redness and eye pain, along with intolerance to light and lateral deviation of eye since 4 to 5 months. The visual acuity in the right eye was 6, 6, and 6, but in the left eye was counting fingers close to face. Intraocular pressure in the right eye was 12 millimeters of mercury, and in the left eye was 6 millimeters of mercury. The history showed that there was no fundus view because of the media haze. The details of media haze were not noted. The ultrasound scan is also quite old. But the ultrasound shows that vitreous cavity shows uh, few low reflective dot echoes along with membranous echo noted uh, extending from the posterior part of the lens with clump echoes of dot echoes extending the membranous echoes are extending from that clump echoes towards the optic nerve head. So clinically the diagnosis was made of toxocara. The anterior segment was showing posterior synechia and central lens the haze was there, so ultrasound was advised. And this was the fundus photo of Optos image of the fundus of this eye. There is granuloma located here inside, just beneath the lens, and the membranes are extending from the granuloma towards the optic disc. So, patient was diagnosed with toxocara canis.
Devika, is it a posterior granuloma or a peripheral granuloma?
Peripheral granuloma inferior to the disc.
But I think in the image you mentioned granuloma is over the disc. You told everything is going and attaching to the ONH in the second image, the ultrasound image. If you see in the first scan, the ONH shadow just shows some membrane kind of thing. So
Yes,
the second scan is the inferior scan, right?
Yes, ma'am.
So it is a peripheral granuloma
Peripheral
with some
granuloma.
membranes going from the optic disc.
Yes.
So why were you mentioning that? The membranes or whatever they are going from lens to the granuloma. Why? I mean,
Ma'am, in toxocara, classically the granuloma presents in the periphery of the.
no. You did mention that everything is going from the lens something because I'm just curious.
No, ma'am. I wanted to tell that the granuloma was just beneath the lens in the periphery, and the membranes were extending from the granuloma towards the optic disc.
You mean to say anteriorly the granuloma and the lens are proximal? That's what you mean to say?
Yes, ma'am. So, this is the inferior scan, and this beneath the lens echo inferiorly and the anterior part of the eye, there was a granuloma.
Where is the granuloma in the image? I think you are getting a little confused. It is a peripheral granuloma, inferior quadrant, and point out the granuloma.
The image is slightly curved, but it appears to be here somewhere.
What are those two lines joining?
So then what is?
Because see, this is not an optic disc there because the optic disc shadow is not there. The this scan, if you're talking about, see what is there on the optic disc shadow there. I think so that's not a disc area, right?
The granuloma is anteriorly over here in the fundus image. We can see that this is the optic disc. The membranes are extending from the disc towards the peripheral granuloma. So patient posted for vitreous biopsy, and vitreous aspirate was PCR was done for the vitreous aspirate, which showed Eubacterium genome positive. The Toxo IgM and CMV IgM was also positive. So patient was started on systemic and topical treatment. Vision on after systemic treatment improved to 6/16, and patient was they were later following up with his local doctor. So further follow-ups were not done.
I think you have to specify what was the systemic treatment.
Patient was started on steroids, ma'am. Systemic steroids.
Because you have shown that so many are positive. So basically it was treated as toxocara.
Yes. So coming to the ultrasound in ocular inflammation, the things to look out in cases where we suspect intraocular inflammation is the vitreous echoes or membranous echoes, retinochoroidal thickening, retinal detachment, choroidal detachment, and subtenon space widening. 59-year-old male patient complained of pain and redness with blurring of vision in both eyes since 4 to 5 months. Patient was started on oral steroids elsewhere, which was taking 10 milligrams per day since 1 month. Patient had stopped the medications on his own after taking for 1 week. Patient further noticed diminution of vision in right eye since 1 week. Visual acuity at presentation was perception of light present and projection of rays accurate. Left eye vision was 636 and 36. Intraocular pressures were normal. Anterior chamber and anterior vitreous phase was quiet. Pupils were sluggishly reacting to light. This was the fundus image, which shows classically the sunset glow fundus because of choroidal depigmentation. So the ultrasound was done in the right eye. The ultrasound shows definite lens equals.
Hariba. Quick, no?
Ma'am, it's an ultrasound image of the right eye, shows definite lens echoes, and in the right side image, there's a hyper echoic membrane with the spike on A scan, uh, possibly localized retinal detachment, but it is not attaching to optic nerve, so we cannot say exactly just based on the reflectivity and spike I am saying. And
What else you can make out on the axiom? Something which is also seen in the other scans also.
thickened choroid.
And you want to give any other information regarding the two images on the right side?
Yes, ma'am. The first image was taken in supine position. So there's the
Shifting fluid.
Yes, this is the supine position, and when patient was asked to sit up and the ultrasound was done, the fluid was shifted inferiorly. So this was a classically sign of shifting fluid, suggestive of exudative possibility of exudative retinal detachment. The left eye showed few dot echoes in the vitreous cavity. The axial scan is not there, so this scan, the posterior lens, the lens echo is noted. Slight retinochoroidal thickening is noted, but retina appears to be attached.
So what is that you are seeing in the left hand side? There is an RC elevation. No? I think there's a shallow RD in left eye too. How will you explain that membrane echo? Yeah, that one.
Yes, ma'am.
Probably inferior.
Probably of on clinical examination there was no retinal detachment noted, but the scans
you are
is
only put that image.
suggestive.
No? You only put that image.
Yes,
It is showing a membrane echo. No?
yes. There is a high reflective membranous echo, possibility of shallow retinal detachment with retinochoroidal thickening. So patient was diagnosed with both eye VKH syndrome with right eye exudative retinal detachment. So patient was started on a course of IV methylprednisolone. 3 doses of IVMP and oral steroids were given to the patient. So patient came back after 1 month for follow-up. On fundus examination, the retina was attached and the exudative component of retinal detachment was came to normal. Patient was currently continued on oral steroids and immunosuppressants as well. He was on tablet Azuran. Coming to the next case, patient, a 55-year-old male patient came with complaints of diminution of vision in both eyes since 1 month. Patient was a diagnosed case of panuveitis since 2018, and he was on oral and topical steroids since then. Patient had stopped oral steroid 2 months back. The visual acuity noted was perception of light in both eyes, and intraocular pressure measured was 7 millimeters of mercury in both eyes. The ultrasound in the right eye showed there were few moderate reflective membranous echoes in the vitreous cavity with the retinochoroidal thickening noted. And the left eye showed moderate to high reflective membranous echo with poor after movements, and it was persisting in low gain. So probability of retinal detachment was suspected in his left eye. On serology testing, patient came with Montauk's positive, and quantiferon TB Gold test came positive. Patient for the same patient was referred to a physician. Also, patient was started on oral steroids, starting from 60 milligram per kg in tapering dose. On follow-up, patient came back when patient was on oral steroids of 35 milligrams per day. Patient had hypotony in both eyes with intraocular pressure of 2 millimeters of mercury, and the ultrasound was repeated. In the right eye, there is high reflective membranous echo noted, and the posterior retinochoroidal thickening is noted. This image shows the indentation artifact secondary to the ocular hypotony. The left eye also showed moderate reflective membranous echoes, and the membranous echoes are focally attaching to the high reflective membranous echo, which was persisting in low gain in the scans, suggestive of focal retinal detachment in the left eye. Patient was advised to continue high-dose systemic steroids and immunomodulators. Patient is currently undergoing follow-up for the same. The follow-up ultrasound is not yet done. Next case is of a 51-year-old male. Patient complained of redness, watering, and pain and swelling in his left eye since 4 days. On presentation, there was corneal edema there, severe chemosis was there. AC was quiet, but circumciliary congestion was present. Intraocular pressure was 26 millimeters of mercury, and best corrected visual acuity was 660 in his left eye. The
Devika, hold.
ultrasound is done.
Urvashi.
In this ultrasound, in the right side picture, no definite lens echo is seen. There is diffuse choroidal thickening. Vitreous cavity is clear. No, very few low reflective echoes. In the diffuse retinal choroidal thickening is noted with the widening clear with T sign, the widening of the posterior space, and in the left hand side inferiorly there is definite widening of the subtenon space.
Diagnosis.
Posterior scleritis.
So patient was diagnosed to have posterior scleritis, and patient was started on IV methylprednisolone 3 doses followed by systemic steroids. After the treatment continued for 2 weeks, the subtenon space widening is comparatively reduced, but the retinochoroidal thickening is persistent. Patient came down to best corrected visual acuity of 6.9, and patient is currently continued on oral steroids and methotrexate as well. Coming to a few differential cases which can mimic ocular inflammatory conditions. Patient came with complaints of gradual diminution of vision in both eyes since 2 months. Patient had cataract surgery done elsewhere 1 month back. So vision was progressively deteriorating post-operatively. Patient was elsewhere diagnosed as left eye endophthalmitis and advised was vitrectomy with intraocular antibiotics. Patient came for a second opinion. Not a known case of any systemic illness. Visual acuity in left eye was 3/60 and 18, and intraocular pressure was 10 millimeters of mercury in left eye. So the ultrasound was done in. There's.
Devika, hold. Rahul.
With gravity is relatively is having low reflective dot echoes. We could see retinochoroidal elevation. Probably in the right side scan is showing a retinochoroidal elevation with the variable reflective membranous echoes on either side of the lesion, and overlying vitreous is also showing some low reflective dot echoes.
Okay. So we'll come to this later. What is this? But you go.
Yes. On fundus examination, there was a hazy view of fundus, but the retina was visible. This is the optos image of the fundus.
So optos is not actually showing the VPT.
Yes.
You can see those exudates in the macula. That paramacular exudates is what actually prompted to look more in the ITQ. And to be very honest, I didn't pick up the VPT. LG sir picked up when I asked for second opinion. So this case was referred as post of endophthalmitis. So it was looking a proper with haze. So, but this exudation, something felt off. So then when I would have advised vitrectomy on the same day, but the proteinaceous hue of vitreous. So that's what sir taught, and I should thank sir for diagnosing and helping with this case. So any case, even if it is a post of endophthalmitis suspect, that proteinaceous hue, you feel something of, please examine the patient again properly. And ultrasound also, despite ultrasound, I thought it's a subretinal abscess and I missed it actually. So
patient was advised transconjunctival cryotherapy. This is the fundus image. The vitreous.
So the patient's wit haze reduced after course of oral steroids. The patient, because the wit haze was precluding any treatment, for 1 month he underwent a course of oral steroids, and then we could see the VPT. The VPT was cryo was done, and second sitting we did TTT also. Today the patient has come with 618 with minimal edema, and we are thinking to give anti-VEGF. Actually, the last patient I saw today was this patient. You can see that reddish. Can you point out the tumor?
Yes,
Yeah.
yes.
So that is the VPT. It is more temporal compared to the conventional location.
Coming to the next case, a 45-year-old old male patient came with complaints of gradual painless diminution of vision in left eye since 2 years. Patient was elsewhere diagnosed with choroidal neovascular membrane, and one dose of intravitreal anti-VEGF was given 5 months back. There was no improvement after the injection. Patient visited another doctor and later diagnosed with retinal vasculitis and currently was on oral steroids. Patient was a known case of diabetes hypertension and was on treatment. The visual acuity in right eye was normal. In the left eye, it was hand movements. The intraocular pressure in left eye was 20 millimeters of mercury. There was vitritis present, but retina was appeared to be attached, and retinal view was hazy. So ultrasound was advised. This is the ultrasound image of the patient. Vitreous cavity shows few the low to moderate reflective dot echoes. Along with that, there is a moderate to high reflective clump echo and the retinochoroidal diffuse thickening. So, for patient was evaluated further, and OCT showed a choroidal mass lesion. Uh, so, diagnostic and therapeutic vitrectomy was done. PCR came negative, and the culture also showed no growth of any organism. ECG echocardiography came normal. MRI also was done to rule out any brain lesion, but MRI was showing no parenchymal lesion. Bone marrow aspiration biopsy came negative. CSF showed also no lymphoma cells were noted. So, after the opinion of hemato-oncologist, ocular oncologist, and a neurosurgeon, it was thought to treat as a primary intraocular lymphoma. So, patient was advised intravitreal rituximab 1 milligram per 0.1 ml, and patient is under continuous treatment for the same.
What was the HP result of our diagnostic and therapeutic vitrectomy? What's that?
Ma'am, it was inconclusive. There was no any HPE came positive for lymphoma cells. The smear and histopathology of the vitreous
sample,
aspirate,
right?
the diagnostic.
You have to put that. No?
Yes.
That is why we were
That's-
inclined towards lymphoma, right?
Yes, yes.
So any case of diffuse retinochoroidal thickening with vitritis in elderly, especially women, we have to keep lymphoma as differential.